Hi, my name is Kelly Ormond, and I am the director of the Genetic Counseling Training Program at Stanford. I also have training in bioethics, and I am going to be speaking today about genetic testing of children and the ethical issues that are related to it. I do not have any financial disclosures related to this talk, but as you will hear later in the talk, I was a member of several different work groups for different professional organizations that dealt with issues surrounding genetic testing in children. Some of the learning objectives that I'm hoping that you get out of this talk today are to be able to think about different components of consent that are most relevant when we're talking about genetic testing to minors in different situations, and to know a little bit about the different professional organizations' statements that make recommendations in these areas, particularly around predictive genetic testing of adolescents. So in order to begin thinking about genetic testing, I really want to ground our discussion by thinking about all of the different times and situations when genetic testing may happen for children. The most common situation is going to be a diagnostic testing situation, and those originally were things like karyotypes or ACGH. Now it's more likely to be single gene testing, panels, exomes, and future genomic testing in other settings. Predictive testing can be anything from newborn screening to testing for conditions where there are not symptoms currently but may have later childhood onset. Predisposition testing is more going to be the testing for adult onset conditions, or even carrier testing might fit into this category. And then obviously there are going to be secondary or incidental findings that can come up in all of these settings. So first I'm going to talk a little bit about the diagnostic testing, and this is really where most of our genetic testing is going to be happening. So if you're working in a pediatric genetic testing setting, you're working in a medical genetics clinic, this is when you have a child coming in who has a number of different medical issues, possibly some intellectual disability, and you're really trying to come up with a diagnosis because the family is interested in this and more information on prognosis. So this is going to be more focused testing. This is really the primary reason why we're doing testing. In contrast, when we get into things that are more predictive, newborn screening is a great first example of how this works. And most of you will know that newborn screening started in the late 60s. We had very clear criteria for screening, the Younger and Wilson criteria, and these were conditions that would not otherwise have been diagnosed in that immediate newborn period of time, but the diagnosis was very important because it could change the outcomes if we did the diagnosis and treatment. Now newborn screening has expanded quite a lot, and again, it's important to point out that these are usually not DNA-based tests, but may be biochemical tests in some way. And then if you imagine all of the things that one might find out from something like an exome, we end up with situations where we have a primary testing purpose. So these are going to be the colors in green here, where we might have phenotype-related pathogenic, likely pathogenic, or VUS reports. And then all of the sort of secondary types of reports that we may get back from an exome. So these could be things that are in genes unrelated to the clinical phenotype, carrier status, pharmacogenomics, and true secondary and incidental findings. I want to stress that secondary and incidental findings can happen with any genetic test, and this is not new. So even back when we were doing karyotypes, we might incidentally discover translocations or sex chromosome abnormalities, or ACGH can discover large duplications and deletions that not only explain the symptoms that are present in a child, but might also predict future issues, such as a cancer gene deletion. And then something that we often forget about with testing of children is that both prenatal diagnosis and newborn screening can often discover carrier status, which is not typically disclosed in healthy individuals. We normally do not do carrier testing in children, but if you learn it during a prenatal testing situation, it is usually disclosed. So this is an interesting contradiction to some of the things that we'll be talking about in the course of this discussion. So what I want to do now is really back up and start by thinking about how we approach informed consent in genetic testing in general. And I use this slide to convey a number of different things about informed consent in a very general way. These two photographs can be used as examples of how we think about informed consent. So in this picture on your left, you have some individuals who are going on a day hike. On this picture here, this is flying over Mount Everest. And if you imagine that informed consent is just like thinking about the difference between these two hikes and what someone would need to know, that's really the standard that I try to take into account every time I think about informed consent. So in order to prepare for this day hike, you need to think about what the risks are of doing that hike, what you need to bring with you, and you need to feel comfortable that you can take that on. That is a completely different conversation than planning to go, for example, to base camp or to try to summit Mount Everest. Informed consent is the same way. You have to think about the magnitude and frequency of risk in order to consider what needs to be conveyed. Of course, all of us in genetic counseling know that informed consent can be very complicated and that the amount of information is really critical. And we tend in genetic counseling to overload educational information, thinking that this concept of fully informed consent is going to lead to informed consent. And I do want to stress that both with children and adults, having too much information can simply overwhelm people and not necessarily lead to good quality informed consent. So my first question to pose is whether or not informed consent is different for genetic testing as compared to other areas of medical informed consent. There are a few key differences that are going to play out here, obviously. One is that in medical informed consent, we're traditionally talking about physical risks. So this is the kind of thing where you're undergoing informed consent, let's say for a surgical procedure, and there are physical risks that you may be undertaking in order to have that. There are frequently also medical benefits or medical actions that one would gain by consenting to something. In contrast, most of the time, genetic testing doesn't have a significant physical risk. It's a blood draw, it's a saliva sample, it's a cheek swab. However, these may have psychological impact that can really vary significantly from person to person, and people may make different decisions. So this is why we have really focused so much on autonomy and this notion of informed choice and values-based decision-making within the field of genetics. And this probably comes out of the fact that people who have experience in their own family with a medical condition make quite different decisions than people who may not know anything about it, and even within the same family, they're making different decisions. All right, so when we think about informed consent for adults, we really have to start with the notion of capacity, and this is especially relevant to talking about genetic testing in children. Decision-making capacity requires that an individual understand and appreciate the nature of the action that they're taking, the relevant information about it, and the options that are available to them, including the risks associated with each option. And they need to be able to express a voluntary choice. So that is the standard that we hold for people making any medical decision who are adults. And decision-making capacity can vary depending on what the decision is. So a person might have decision-making capacity for one decision but not another. And decision-making capacity can change over one's lifetime, both in permanent ways. So someone who has dementia, for example, would lose decision-making capacity. Someone who is having a psychiatric illness may have transient loss of decision-making capacity, but perhaps at a later point in their illness or when they're medicated, they may regain their decision-making capacity for certain things. So decision-making capacity is a really critical concept. And in general, if someone has transiently lost their decision-making capacity, we do try to delay decisions so that they may make their own choices when their decision-making capacity returns. We're going to talk in a minute about surrogate decision-making and how that plays into all of this as well. First, when we're dealing with an adult who has capacity, there are going to be some components of informed consent that are educational. So in genetic counseling, that may include any number of these components here on this slide. But obviously in genetic counseling, we're not just talking about content, we're also spending quite a lot of time talking about the emotional issues that may go along with learning potentially predictively about a disease risk. And of course, we know that individuals have quite different views about what they would want to know about and what's going to influence them. When we talk about this around childhood genetic testing, there are going to be a lot of factors that might influence this testing process and the adaptation to results. So this may include the age of the child, various features of the condition, and whether or not there is a family history of this condition and who in the family has it. Now, finally, I want to say a few words about surrogate decision making. When someone does not have capacity, when an adult does not have capacity, there are two different ways that their surrogate could make a decision. Most frequently, we aim to have a surrogate use substituted judgment. So this is, for example, when an adult says that they have a designated person who will make their decisions if they're unable to, and that surrogate is meant to think about what they have learned from the adult who previously had decision-making capacity. So what would this person have done? What would they have wanted from themselves? What data do I have about what's important to them or how they've made these decisions in the past? Sometimes we have an individual where we don't have the opportunity for substituted judgment. Maybe no one knows this individual, they've never expressed particular values in this area, or they don't have a designated surrogate period. In those cases, we focus on best interest. What is the best interest of this person? That is often used if the person never had capacity, and that's going to be the manner in which most decisions end up being made for children. So now I'm going to switch gears and talk specifically about genetic testing of children. And again, as I've just said, usually we are focused on the best interest of the child in these decisions, and it is taken for granted that parents will make decisions on that basis when they're making any medical decision for their child. That said, any of you who are parents or who think about how things work in your own families know that it is impossible to truly separate the relationship of the family from decisions about any individual child. The other thing that's really key is that we assume that most children are going to have some degree of developing competency, and that as they age, it is not necessarily a linear thing, but that as an individual ages, they gain that competency. Obviously, this won't be as true for individuals with intellectual disabilities, but for many of the children that we're talking about, it will be true. So how do we decide what is in the child's best interest and who gets to decide? This is a table from the 1995 ASHG ACMG position statement that really laid out a lot of the key things that we focused on and in fact continue to focus on in this way. So the first thought is, what are some of the potential benefits of genetic testing? And certainly, if we focus on the medical issues, we would be thinking about areas where knowing the result of a genetic test is going to change medical management. So this is getting into the medical actionability. Can we do treatment, surveillance, and screening if we know who's at risk? Can we avoid screening someone if we know they're not at risk? So, for example, maybe here we're talking about something like familial adenomatous polyposis, FAP, and we have people who are at 50% risk, and they may start screening early, and that may be an invasive screening. So we could screen those people in a more targeted way. That would be a potential benefit of genetic testing. Or we have a child who's at risk for retinoblastoma, and rather than sedating them and doing screening on a regular basis, genetic testing might be offered to target the screening and surveillance to only those who have a specific mutation. It may also refine the diagnosis and prognosis. Okay. The other thing that we often focus on is potential harm. And here we're talking more about the psychosocial issues rather than medical issues. And you can see a whole list here around potential areas where the child or the family around them may have a psychosocial response to learning about genetic information. Also, of course, potential for discrimination. The traditional arguments go against testing children unless there is a near-term medical benefit. And there really are 4 different reasons why that has been the focus within genetic testing and genetic counseling. The first is the notion of preserving the child's autonomy to choose to have the testing or not once they have that decision-making capacity from themselves. This is built on the notion that there's a lot of variability, particularly around predictive testing, for who wants to know this and who doesn't, rather than seeing, for example, that 90% of people would choose to do the testing. The second point is around privacy within families. So the idea that a child may decide to learn a piece of information when they're an adult, but they may decide not to share that with family members, and that is not something that they can do if they're tested as children when the parents are involved in that process. Third, the potential harms, and these are the issues that we've talked about on the prior slide. And then fourth, a question about whether or not someone who is tested as a child for a condition that has future impact will understand that result or remember that result. And also the question about when in that time trajectory results are disclosed to the child. So for example, if a 5-year-old is tested for a condition that's not going to happen until they're in their 30s or 40s, are they told when they're 5? Are they told when they're 10? Are they told when they're 15? What does that process look like? And where are those results stored in a medical record? All right, so this is where genetic testing really started in terms of testing for kids. The first point, if testing offers a near or immediate medical benefit, that has typically been seen as an effective and useful approach to genetic testing. So this would be the example of doing a karyotype or an array or a single gene test or a panel to find out what's going on, make a diagnosis, and be able to prognosticate and treat. This would also be the example of newborn screening, where you do the newborn screen, you identify the kids that are positive for a particular condition, and then you offer that treatment in order to prevent a bad medical outcome fairly immediately. So that's very clear-cut. There's very little debate about that. Now, slightly different than that is when you have a medical condition and a genetic test where the child is not yet symptomatic, you would not yet be treating anything, but it may be a nearer term onset. So maybe this is testing a newborn child for cystic fibrosis or Duchenne muscular dystrophy, where it's going to be a little later onset. There's a little bit less data about the medical treatments being influential in the immediate near term. But maybe that family is going to have another child, and this could influence whether or not they have a second child or whether or not they do screening, let's say, in a second pregnancy. This may also get into some of the conditions like carrier screening. The next 2 categories are going to be the more controversial ones. This is where we're talking about having no medical benefit in the immediate setting, so talking about adult predictive testing for the most part, and then also talking about reproductive and life planning benefits being more long-term than short-term. Okay, I really like this article by Mand that came out in 2012 because it has a couple of nice tables that really lay out the arguments against testing minors in a little bit more detail and also give you some excellent references for those, and then the arguments in favor of it. And I think that, of course, what we end up doing by default is we end up focusing on these. The arguments of psychological harm and of negative effects. It's really important to remember that we hear from families that there is a significant psychological benefit in decreasing uncertainty, both for the individual and for the family. And there is an emerging body of literature, particularly around things like carrier screening, that suggests that it allows people to prepare for the future. It allows them to think about their self-identity as they're going through adolescence, and to really, that can have a positive impact on autonomy. So I do want to really stress during this talk that there are both aspects in terms of positive and negative psychological impacts that are possible. So now what I want to do is talk a little bit about some of the professional guidelines that are out there and where they land on these. And the first guideline that emerged was in 1995, so 25 years ago, basically. And this was a joint position statement from ASHG and ACMG at the time. As I've talked about already, they had a significant focus on timely medical benefit being the main justification for genetic testing. If those benefits would not accrue for some significant period of time, they strongly recommended that genetic testing be deferred. And so this is where most of you will have the sense that we simply don't test children for adult onset conditions. They did go on, though, to talk about the notion that if one had equipoise, if the balance of harms and benefits was unclear, that competent adolescents in particular and their families could make decisions to move forward with testing, and that the provider should be respectful of those decisions, but that if the harms clearly outweighed the potential benefits, testing should be discouraged. And then finally, competent adolescents who were requesting genetic testing should be given priority over parental requests to conceal information, and the provider is meant to advocate for the child. So those were really critical components of this early statement. Since then, we've had two revisions to these statements come out. The first, ACMG partnered with the American Academy of Pediatrics and published a statement in February of 2013. And really this maintained a focus on the best interests of children and the notion of genetic testing and informed consent being critical. One of the major differences from this early statement was how much genetic testing had evolved since that time. So this particular ACMG AAP statement differentiated between different types of genetic testing in a lot of ways. They affirmed that medically appropriate testing, diagnostic tests, newborn screening, and even pharmacogenomics were considered quite acceptable and with low stigma. They loosened the guidelines from the prior statement a little bit to say that in some situations, predictive testing might be acceptable, but that it still should be discouraged and not routine. And then they very specifically discouraged carrier testing unless there was a specific reproductive planning situation. They also discouraged direct-to-consumer testing of children in this statement. Shortly thereafter, an ACMG position statement came out, and I was one of the co-authors on this statement. And this statement had a lot of overlap with both the 1995 statement and the ACMG statement. And it was a little bit more liberal, particularly around carrier screening as compared to the ACMG statement. I would encourage you to read all three of these statements for the historical perspective. So what I want to focus on now as we conclude this talk is some information about predictive testing, because this is really the crux of where the controversy lies. And I think that it's important to start off by saying that predictive testing can be different. There are some conditions that are going to be childhood onset, but haven't happened yet. Again, these can help parents feel prepared. They can help them prepare children for some of the screening. They can decrease the number of invasive screenings that are done potentially, since many of these are going to be dominant conditions with high penetrance. That's going to be really different than offering testing for a condition like BRCA or Lynch syndrome, where we may have early adulthood onset, or even things that may be adult onset neurodegenerative conditions where we may have less treatments for. There's some interesting and I think unresolved questions about whether or not learning that one is at risk for these adult onset conditions changes healthy behaviors in a positive or negative way. Okay. So again, really, really different conditions here. Just to remind you, thinking about these key issues. Are we preserving autonomy? Do children deserve privacy? If I were to go back to these conditions and think about that, one of the things that's really useful to look at and that has evolved in the data quite a bit is, what do adults choose? And I think that for many of the conditions where we have good screening and prevention, we see that a high percentage of at-risk adults are going to choose to do that testing. Whereas if we have less medical actionability, for example, or things that are really, really invasive, such as sudden cardiac death conditions where maybe an ICD is the treatment, we may see more variability there around the percentages of people who get tested. So the question about preserving a child's autonomy could be considered from the standpoint of whether or not people make quite different choices with adults or not. And then we're going to talk a fair bit about this question of potential harm. Okay, so these are some of the things that we've seen previously around testing uptake. We may be a little more flexible then about considering adolescent testing in situations where we know there's a high testing uptake as compared to situations where there is more variability. All right. When we're thinking about predictive testing, most of what we've talked about so far are the value claims, these issues of autonomy and confidentiality and paternalism. But in fact, there are empirical claims as well, and this is around the harms. And since some of these original professional statements have been written, we have more data. So I want to take a minute just to talk about some of that data. There's not a ton of it, and there certainly are biases, but the crux of this is that most of the data that is out there, and I will present you with a couple examples of it, suggests that any changes in anxiety and depression and adjustment are just as transient and minor as they are in adults who undergo genetic testing. And obviously that negative results in these high-risk families can go really far to reduce anxiety and depression, both in the parents and in the children and adolescents. So I'll give you a couple of examples here. And the primary examples that we have good data on are FAP and then BRCA. So the first point here, these are some studies out of the early 2000s out of a couple of the Johns Hopkins groups. And what you can see here is, just to orient you to this slide, we have adults and children who underwent genetic testing. You can see negative results, positive results, negative results, positive results. And the key things that I want to point out here are that, first of all, when testing was done, we see that there's a higher recognition of the risk perception. We also see that there's higher confidence in these test results. I'm going to go to this slide. So you can see the sense of the perceived chance before and after is more accurate, although I will point out here there's a little bit of anchoring and the results go back up a little bit in people who tested negative. Higher confidence across all of the groups. Worry goes down in both groups, including those who tested positive. So that's really important to recognize. On this slide, we have those who tested negative and those who tested positive. And essentially, we're seeing similar scores in depression, anxiety, and some of the behavioral areas. Thinking about adult onset testing, for breast cancer. Most people don't realize that there are actually a significant minority of geneticists who are willing to consider this testing on a case-by-case basis. Oops, sorry about that. And there are plenty of published examples of providers who are doing BRCA testing on adolescents. So there have been a couple of studies by Angela Bradbury and that group that have looked at parents and children's views towards genetic testing in this area. One of the things that I think is very interesting about this particular set of data is that most people who are opposed to genetic testing of minors are not saying they're opposed because they want to preserve autonomy, which has been one of the main value arguments around why we don't test children. So you can see that right here. It should be delayed so the offspring can decide. Only one individual, who was a daughter, actually selected that as their reason for saying that genetic testing should not be offered to minors. But you can see there's quite a lot of support for testing here, and that's primarily in the hopes that it would foster healthy behavior and that offspring themselves have a right to this testing. Primary care providers are mixed about their willingness to offer it, but you can see here that nearly half of them are either neutral or agree with the offer of testing, and that those numbers increase if there is consent and assent by different family members and if genetic counseling is performed. So while the data remains limited, most of the data, as I've said, suggests that the harms are not as big as what we worried. I think it's fair to say that current practice is to discourage testing in general, but if there is a situation where we have a family that's very anxious or where the adolescent is supportive of testing and the parents are supportive of testing, that one might have a discussion and really try to consider what that would look like. So I'll just show you the way the different professional statements deal with this. So this is from the American Academy of Pediatrics and ACMG, and you can see here, parents or guardians may authorize predictive genetic testing. Ideally, the assent of the child should be obtained. Predictive testing for adult onset conditions generally should be deferred unless an intervention may reduce morbidity or mortality or diagnostic uncertainty is posing a significant psychosocial burden, particularly when the adolescent and the parents concur. All right, and again, just sort of stressing caution here. The ASHG statement, you can see encouraging families to consider decisions over a period of time, may make it clear to families if testing would be helpful or if deferral would be helpful. Again, unless there's a clinical intervention in childhood, parents should be encouraged to defer at least until the child is an older adolescent and can participate in the decision-making in a mature manner. Adolescents should defer testing for adult onset conditions because of the complexity here. And providers should offer to explore the reasons why parents or adolescents are interested in this testing. All right, adolescents should be encouraged to discuss these issues both with parents and without parents. Referral to genetic counselors can be useful here. And again, more empirical research being important for future policy recommendations. I want to end this section by giving you a nice quote by Lainey Ross, who's a pediatrician and bioethicist. And this really gets at the crux of how we think about many of these decisions here for individuals who have developing autonomy. Proxy decision-making is more restricted than individual autonomy because individuals may take risks that they cannot authorize others to take. Okay, so I'm going to switch gears and talk for a moment about carrier testing, and the ASHG position statement did spend some significant time on this issue, and it was controversial because there's quite a lot of data around carrier testing in adolescents, both from the US and in particular from other countries, including Canada and Australia. Most of these studies suggest that there's pretty good recall and some potentially beneficial psychosocial outcomes in both carriers and non-carriers. But because there was such variability across the U.S., ASHG really felt that they could not fully support that. So they neither recommend nor discourage offering carrier testing to adolescents. I'm going to switch gears now and talk about the context of sequencing in children and some of the special issues that this brings up. So, as you all know, sequencing is really becoming first-line testing in many pediatric genetic settings. One of the big challenges here is that sequencing is going to give you test results that are going to be much broader than that diagnostic area that is the primary indication for testing. Many incidental and secondary findings can come up here, and those are going to cross the range of carrier results, which we expect most people would have, pharmacogenomic results, and then potentially adult onset conditions, and there's going to be variation in the degree of certainty around these results and around the actionability that might be possible. So the ASHG statement did talk specifically about this in a bit more detail than the American Academy of Pediatrics ACMG statement did, and you can see here that ASHG recommends that scope be as limited as was feasible. Now again, this statement was published in 2015 when exome sequencing and genome sequencing were not yet anywhere close to a first-line test. So it may already be time for ASHG to think about evolving this statement a little bit more. They were focused here on trying to do targeted testing as much as was possible, and that particularly for healthy individuals, genome scale sequencing was not recommended, including as a newborn screen. This was seen as being in direct conflict with the secondary findings recommendations that came out at that time and then have since been updated in 2016. These statements did recommend that 59 genes be recommended for return when clinical sequencing was done, both in children and adults. And this is the gene list, and those of you who are familiar with this list will know that the majority of these genes are cancer genes or cardiovascular risk genes. Now, this was a hotly debated topic that came up and was seen as being in direct conflict with the AAP-ACMG statement that came out shortly before it, within a period of a couple of months in 2013. One of the key things that I want to stress about this list is that with a few exceptions, almost all of these genes can have childhood onset, even if it is not the most frequent presentation. So that was a really important thing that was discussed. And it was also discussed in the context of returning these results on children as part of sort of the greater good and best interests for the family, because if one had a parent that did not know they had these results and you were only doing a singleton exome, for example, and the parents weren't receiving sequencing in some other setting and this wasn't a routinized sort of thing, the parent may not know they have these mutations, and that by finding it out in advance, we would be furthering the best interests of that child and the family by hopefully promoting better health within the family. ACMG statement in 2015 did talk about secondary findings, and that certainly as much as one could include children to assent in these, that was important. ACMG did say that parents should be able to make these decisions and decline such results as they felt was relevant within their own families. All right, so as I conclude this talk, what I really want to end on is encouraging you to think about the role of a genetic counselor in this situation. Long ago, many people felt that genetic counselors were gatekeepers to testing. So this was the notion that we were preventing parents from getting test information that they might otherwise want. I would like to encourage you to see yourself as a partner in decision-making around childhood testing, helping parents think about why they desire this information, what they are hoping for and expecting, how they think they might behave if given these results, and whether or not their own anxiety is the driver versus really trying to do something that might impact their children well. And I found in my own clinical practice that if one engages in these conversations, oftentimes we can really help parents evolve in their thinking, and they may realize some of the reasons why it might be beneficial to defer testing versus be able to more clearly think about and articulate their reasons for desiring it. And that by working together as a partner around childhood testing, we can help families reach good outcomes for everyone involved. So hopefully we won't be just tripping over Pandora's box or keeping it locked up in the closet, but that we'll really thoughtfully be trying to convey information and guide decisions in a useful and collaborative manner. And so I'll end there and hope that I've given you some interesting things to think about and some good background around genetic testing